Hey, I'm Sarah Smith, family doctor, clinical day advisor, and the chatting coach. Welcome back to Sustainable Clinical Medicine podcast, where we're going to be interviewing peers or world experts who can help us think about our clinical day in a way that is more sustainable and create time for our lives outside of medicine. We are celebrating 5 years of the Charting Champions program. The program opened in October 2020 with 77 founding members, and we now have a thriving community of 1,500 doctors. We are so proud of our members. Inside the program, we give you strategy plus clinical day advisors, and that is getting you results. Over the time of the program, we've been monitoring our members' success. We've seen a significant decrease in the hours spent charting, the hours doing clinical paperwork outside of the clinical hours, and no significant difference in the number of patients seen in a full clinical day. In addition, our doctors reported feeling more focused at work, feeling in control of their clinical day, and rating their mental energy at work as significantly higher. Our doctors reported an increase in their current quality of life, a decrease in work-related dread, a decrease in feelings of burnout, and a decrease in thoughts of quitting due to administrative burdens. We know that the Charting Champions program reduces the time doctors spend on charting or tasks outside of the clinical hours and increasing free time and quality of life. Now it's your turn. We have a significant birthday bonus available for you, and we'd love you to join us inside the Charting Champions program. We're going to be having a kickoff call for our new members and our existing members, so you get to meet the community. You're going to get a one-on-one call with me, and that's not something that you can normally buy. So that's a special gift to you as a thank you for joining our thriving community. If you want to learn more, come along to the free live workshop that we're having this month. Head to chartingcoach.ca and you'll see the link right at the top of the website. I'm so excited that we have been helping more than 1,500 doctors inside the Charting Champions program over the last 5 years, and we're just getting started. I want to invite you inside this thriving community, start getting the help you need to create time for your life outside of medicine. Hello, everybody, and welcome back to another episode. Today we have with us Dr. Laura Suttin. Welcome.
Thank you. Good to be here.
Excellent. All right, tell us a bit about you.
So, I am a family physician by training. I live in Texas. I still practice medicine. My full-time day job right now is my business where I do consulting and speaking and coaching, primarily in the medical space with healthcare organizations and coaching physicians and medical professionals. I love it. I started coaching about 5 years ago and I just love it.
Excellent. All right, so tell us about your journey in medicine, in family medicine, uh, and the challenges that you faced.
Yeah. So I started practicing, well, after residency, I joined a small private practice that a couple years later then was sold to a larger healthcare system that, like a lot of healthcare systems, has grown over time. And so as part of that, I'm doing full-time clinical practice and then slowly started to do some administrative leadership, and then kind of slowly decreased my clinical time and increased my administrative time. And I'm really actually grateful for that opportunity. I know that sometimes the admin work can be considered grunt work, but it really gave me an opportunity to work with other clinicians and help understand what are their pain points. So a lot of the work that I did was around improving our operations, improving efficiencies for clinicians, and changing systems so that clinicians feel valued and are really practicing at the top of their license and very fulfilled. That led me to coaching. So I started coaching in 2020, started my own business. I was doing coaching internally within the system that I worked with, and then coaching within my business. And in May of last year, I left my full-time job at the with the healthcare system, and so now my business is it's yeah, full time consulting and coaching and speaking. And I also do practice here and there, about one shift a week, in a local urgent care, just because I realized I missed that part of practice, and it helps me, keeps my skills up, helps me stay connected. So, um, yeah, so that's a little bit about me and my journey.
Tell us about you in family practice before you moved into administration. Were you having challenges? Were you finding the system wasn't working for you? Were you asking for help or asking for things?
So when I started, it was 2007 when I finished residency. I know I'm dating myself. Um, EMRs weren't new, but I hadn't worked with one in my residency, so learning how to get used to the EMR was challenging. Luckily, the one that I used, I was able to adapt to pretty quickly. Um, and then most of my practice transitioned into a very managed care heavy system. And so there's a lot of documentation requirements within that that you might not see in a private practice. Again, not to say that private practice, I mean, there's so many things. I don't think I could have done private practice because in a managed care organization, we had a ton of support. We had a lot of social support for our patients, and just a lot of administrative support for us that I wouldn't have had in private practice. So just very different challenges. And I think, I went into private practice, or I went into family medicine because I love taking care of all different types of challenges. And that kind of still speaks to all that different hats I wear today. I like doing different things. But at the same time, within primary care, we want to be able to spend a lot of time with our patients. We really want to get to know our patients, and we want to do everything we can for them. And a lot of times we're the ones that they see right when they come out of the hospital. We're the ones that they come to when their child died by suicide. I remember seeing that, a patient whose child had like the week before died by suicide, and it's one of those things that you just want to try. At least I felt like I wanted to fix everything for my patients. And realizing that I couldn't. I mean, no one can, but as a young physician, of course, we try to do everything and be everything for our patients. I also had a young daughter at the time, and I was lucky that my now ex-husband, but we were married at the time, stayed home with her for quite some time. But really, just he stayed home with her for first year and a half of her life. I would come home from work, and she would go to him when she would fall down and scrape her knee instead of come to me. And so it's just those little things like I knew I was missing out on time with her. And I felt I think I had a hard time feeling like I could be as effective as I wanted to in the practice space. And I think honestly that's probably why I cut back and did some more administrative work, because I needed my brain and my nervous system needed a break.
Mm-hmm. Mm-hmm. Got it. Tell me about those early years within administrative work. What came up for you? What were the things that you learned, maybe by baptism of fire, that you didn't know, or things that were going on for others within this space that you were maybe not aware of that you needed to start to learn how to manage?
Yeah, I think the politics of working within a leadership team, learning how to navigate the balance between administrative and clinical, because I would start out like, well, I'm in clinic 4 days, and then administrative is my other day, and then but on that fifth day, you're still getting messages and refill requests. And so how do you deal with that? How do you deal with emails coming in on a meeting you were at yesterday, but you're in clinic and you're expected to respond to it? Um, Lots of those different types of challenges, and that actually helped me to just hone um, the coaching that I love to do most is working with clinicians who are making that jump into leadership and trying to balance everything. Um, I mean, it's not easy, just like being a full-time clinician is not easy. And so it just has its different set of challenges. At the same time, it allowed me to talk to other clinicians, visit other clinics. One of the things I was working on was taking best practices from one clinic that's they're getting their metrics, they're doing things right. How do we translate that for other clinicians? So I got to see a lot of what goes on, what other clinicians do well, um, and also what some of the challenges that like I might not have a certain challenge at my clinic, but another clinic, their internet goes down every day, or they don't have a second EKG machine and it's a big clinic, and or they don't their autoclave's been broken for a month and they can't do nail trims, and all of these different types of things that just the small things that can make clinicians' lives really difficult. And they didn't, a lot of times didn't feel like they had support, or they felt like they had, well, they put in a work order and 2 months ago and nothing happened. So I was able to be that liaison in a lot of ways, and that was something I'm really proud of.
Okay, that's a really interesting one. We're seeing it done well in one clinical space. Let's go see if we can make that happen in another space where it's not working well. And I know very early on when I'm in the thick of overwhelm and burnout clinically myself, and we had a team come in and say, well, now we want you to measure this. We want you to record this for your patients.
Yes.
It's just a couple of things. We want you to, measure how much alcohol they're having each year if you haven't measured that within the last 12 months. Show us how many fruits and vegetables and how much exercise. And I would
Yeah.
throw up my hands and be like, do you not understand what I do each day?
Yeah.
You can't ask me to do more. It's
Oh,
not just,
yeah.
it's a conversation like, ah! So there's a lot of anger that
Yeah.
goes on with those suggestions coming at you. And I
Yeah.
would expect that you came up with a lot of, you want us to do what now?
Oh yeah. Oh yeah, all the time. And the fact that I was practicing at the time, and I was I was eating what I was doling out too, or it helped for me to see that, okay, this is, I might be practicing a half day or a day a week, and these clinicians are dealing with these things day in and day out. And so it helped me to translate to my leadership and to people that were making these decisions and recommendations, that every time you ask the clinicians to do, oh, just one extra thing, just one extra thing, it's a death by a thousand paper cuts. You keep asking them, and what's the stat on how many things our brain can hold in one at one time? It's like three, right? And so you keep adding on to clinicians' workloads, and something's going to give. Something's going to give. Um, and yeah, and managed care is all about metrics. And yet, I think there are better and easier ways, especially with AI software, and there's so many different ways that this information can be captured, rather than telling the clinicians, here's another set of 5 questions that you have to ask the patients, because then the patients would get annoyed. um like, if it was January and they have to have the questions done once every calendar year, and they were just seen in December, they're like, I just filled that out, or I filled it out but nobody talked to me about it. I filled out a PHQ-9 and their score was 15, but nobody goes back to address it. um, and then the fruits and vegetables, yeah, like, I don't remember what I ate for breakfast this morning. How am I going to remember my eating habits? So, yeah, it's I was able to see just really the burden that our clinicians are under, because they're being asked to do all these things that are not. It's not that they're not within their skill set, but they have better things they need to be doing with their brains.
100%. And it was the ask is the do more.
Yes.
I don't see that there's ever the questioning of what are you still doing that we need to take off your plate because
Right.
we're asking you to do this thing now.
Yeah.
That means we've hired so and so to do that part for you.
Right. Exactly. Exactly. And yeah, we started to get that. Well, we were getting that pushback a lot. It's like, okay, you're asking me to do this thing now. What are you going to take off my plate? And when we started, we had some pretty significant clinician turnover, I think, like 2022, 2023, kind of coming out of COVID. I think that was a big concern. And so we really started to look at, okay, what are the things that we're asking our clinicians to do that don't make sense?
Mhm.
But yeah, the when the question, or when the command is do more, then the implication is you're not doing enough. And we don't value your time. And so yeah, that was something that I experienced, and personally and professionally.
Do you think as a physician within the administrative team, you brought that voice to the table, or was it already acknowledged that they're doing enough or a lot or too much,
Hmm.
but we?
Yeah.
Or was there, how can we make this system adapt to be able to do what we want to achieve in terms of the metrics, but without the overwhelm and the burnout?
Yeah. I did the best I could, and I wasn't the only one. There were a lot of other physician leaders who were still practicing who we helped to elevate that voice. Um, I think what's the stat on like how many hours a day does it would it take for a family physician to do everything that needs to be done for their patients? It's like they need 27 hours in a day.
27 hours in a day
Yeah,
for a full-time family doctor to
right.
do the
And
work that's
so,
required for their panel of patients. Yes, that's what the study said.
yes. And
27
so
hours a day.
27 hours a day, and that's work time. So, there's it's this bigger question of there's so many things that have to be, we don't have to be, nothing has to be done, but really to take the best care of our patients, there's so many things that we want to be looking at. And as a family physician, that's where you start to get that moral injury of, gosh, I I missed that diagnosis on my patient, or I didn't ask them about alcohol use, or I didn't counsel them hard enough on quitting smoking, or all these things that we, at least I felt like I am not doing I'm not doing it justice. I'm not taking care of patients in the way that I want to be taken care of the patients, and the patients feel it too. And so that's one of the reasons why I really want to work with healthcare teams and clinics and practices, because I've seen what works and what doesn't, and there is a better way. And I have seen it in place where the clinicians are thriving, operations are humming, patients are happy, and also the metrics look good and everybody wins. So how do we reimagine what healthcare can look like so that everybody is flourishing and thriving? And I think that's the question that we need to be asking, is not how do we fit this one process into this already broken machine, but how do we really take a look at, okay, what do we need to get done so that we're not just adding something to a system that's just already so overwhelmed.
Yeah. Can you give us an example of seeing a team thriving? How was that pulled together? What did it look like to disperse the load so that the team was working well?
Yeah, I mean, I've seen teams where the workload is equal to teams that, uh, you know, all the things being equal, including the workload. Some teams hum and some don't. The there's so many things that go into play there. I would say the keystone is the leadership and how the leaders treat their clinicians, the healthcare professionals, the medical assistants, the front desk people. Um, that's where it starts. It has to start with respect and feeling valued, transparency. And so when the people that are working in the system feel that, then they'll work harder for that cause, and they'll do more because they feel a connection to it. And then the patients feel it too. I mean, I think about um environments like Nordstrom, where you walk in and the customer service is just phenomenal, and you can tell that those employees are being really well taken care of, and that they are able to pass that on to their to the customers. And so how do we do that within healthcare? And it's not difficult. It doesn't take much time, and it doesn't take more money. So it's that's something that drives me, is like the things that can really make an impact are, they're not that difficult, and they're teachable skills. It's not like, well, you have it or you don't. It's easy to learn.
Are you working with the clinicians within the system, or are you working with the leaders of the system? Or if you're working with either, what do you teach them? How does that look?
Yeah, I work with both. I started out working mostly with clinicians within the system, and I still love that. I think I've also shifted more towards working with the leaders, because I can have more impact on working with the leaders. With working with clinicians, again, we're talking about burnout and healing burnout and all of that. A lot of the clinicians I work with are, like I said, leaders that are stepping into those leadership roles, administrative roles, and want to know that balance. Um, but one thing that I hear and I feel is that clinicians feel like they don't have a voice. And so when I can help the clinicians to advocate for themselves, and not in a way of, I mean, a clinician's advocating for themselves, people think that lay people might think that's, oh, they just want more money, and that's not what our clinicians are asking for. They're asking for more support, more time with their patients, better systems so that they can get their jobs done. um, and so when clinicians can stand up and clearly ask for what they need and really demonstrate to the decision makers that, hey, this is having an impact on the patients and probably the bottom line, then we can start to cross that bridge, and so the clinicians and administrators can understand each other. And then with the leaders, it's again really just, hey, I know you have a mission and you have to make budget and those types of things. And again, these are some really simple things that you can do to help your team feel valued. Um, and that's one aspect of it. And then it's helping streamline operations too, because that takes a team effort. It really, really does. And so, yeah.
How would we identify a good leader within a system?
Um, gosh, so many different qualities. I mean, I feel like just spitballing here is somebody who's not afraid to get in and do the work. Um, and that doesn't mean that as a leader you don't delegate, but you're not going to ask somebody that you wouldn't do yourself. Ask somebody to do something that you wouldn't do yourself. So that integrity, I think, is really key. Clear communication. I've seen so many leaders that withhold in a way that really diminishes trust. And I understand that there are situations where the frontline staff don't need to know super level details, but if they pick up that something's going on behind the scenes that they're not privy to, or that just that, there's secrets or something going on, that really, really diminishes trust. Um, so being transparent, being clear, and listening to your frontline staff, and then taking their feedback and doing something with it. I've been part of a large organization that did surveys, and so many times the survey feedback was not addressed. And so the worst thing you can do is not ask. The second, or even more worst thing, is ask and do nothing with that information, because people pour their heart out on these surveys and then the leaders do nothing with it. So really understanding what are the pain points that your frontline staff have, and work to address those.
It's kind of like asking your patient to do their depression scores and then ignoring what they said. And then the leaders
Exactly.
doing the same to their staff. Let's ask for their feedback, but I'm too busy to handle that, or I don't have the resources to deal with those questions, or
Right.
yeah, that's nice, but that's not part of where we're going as an organization. Yeah, you can see how frustrating that would be from a patient perspective. You can see how frustrating that would be as a staff member within that organization or that system.
Yeah. Yeah. And people think that, well, I mean, I've heard this before, is like, well, I can't fix up the something that they ask for, we can't do, or they ask for something unreasonable, or they ask for something, that we just whatever, I can't give them what they want. That's fine. I'm not saying that you have to give them everything they want. They might want a one of those bouncy castles in their break room. Obviously that's probably not a good idea, and you need to be able to tell them, hey, this is a great idea. It's not something that we can fulfill. But also dig into, well, why are they asking for that? And do they need a place? I know that's a just a silly example, but do they need a place to go and burn off some steam, or just to kind of decompress for a little bit? And so what is it behind the ask? And is there a way that you can still meet those needs, even if you're not delivering what they asked for? And if it's just something that's not possible, then be transparent and tell them. But ignoring the question, ignoring the ask, people will invent stories in their head. In the absence of information, they'll invent stories, and those stories are going to be way worse than what's actually the truth.
Fair enough. Fair enough. All right. Tell us how to balance this working as a physician and taking on an administrative job. I hear a lot of physicians who get these half day for administration duties or half day for academics, and just trying to decide how do we create room, because like you said, the inbox doesn't stop, the messages don't stop unless we've actually assigned that to somebody else on your administrative day. And then there's also the guilt of, well, I can't leave things in there for that person to take care of that have been sitting there for a
Yeah.
week. I'm going to have to do something about it. It's like tidying up before the cleaner comes, right?
Yeah, exactly. Yeah.
Tell us how do we start to navigate the additional roles and responsibilities in addition to our physician or clinician work?
Yeah. So, I mean, some of this comes from my own experience, and then work that I do with my clients. I'll say every situation is unique.
Mm,
I was fortunate enough to be in a larger clinic with other physicians and APPs that were able to manage a lot of the needs of my patients when I wasn't there.
mm-hmm,
Um, but there has to be clear delineation. So, if you're in clinic. And I got to a point where I couldn't check my email in clinic. And so I just didn't even have my email open when I was in
mm-hmm,
clinic. I would check it later or after clinic or whatever that looks like. I would sometimes have an out of office if I was in clinic. Hey, I'm offline because I'm seeing patients. Same thing with the other way. If your administrative day, then you need to be able to focus on what you're doing. This is knowledge work that we're talking about. We're not making widgets. And so these clinician leaders need to be able to have time to think and strategize, and they can't do that if they're constantly getting interrupted. So some of that might be going to a different physical space. And I've had those conversations with clients of mine that they don't have another workspace other than their office and their clinic. But if they happen to be sitting in their clinic on their administrative day, then they MAs knock on the door, hand them test results to view, or hey, this patient has a question. And that task switching is so challenging. And so there have to be some sort of delineation. So if there's not a physical separation there, can you go to a coffee shop, or is there a corporate office where you can use a hotel suite or whatever that looks like? But setting those clear boundaries and then communicating those, and then, so if that means having a conversation with your supervisor and saying, hey, I need your backup, that when I'm on my admin time, somebody else is going to cover my patients, and how do we work on this? um, I was talking to a client yesterday, and he said that we didn't have time to get into all this, but he said he was in clinic and he's watching emails pop up. And I'm thinking, why do you have your emails pop up when you're in clinic? Like, why do you have your emails pop up anyway? That's a whole other story. But yeah, there have to be some boundaries. And some patients are going to get upset. And the way that I manage this is telling my patients, hey, this is what I'm doing. And the work that I'm doing is going to benefit you. It's going to benefit the clinic. It's going to benefit the group. And I'm really excited about it. And I really love what I do. And I'd love for you to cheer me on. And that would really help. Then they'd be excited for me. Otherwise, they think I'm off golfing or something. So
Okay, tell us some of the rules or the conversations that happen about leaving your patients or inboxes in somebody else's care for those days that you're not in office. So I think that even this is a challenge. So physicians, clinicians may or may not have somebody to help with this, but they may or may not use them. If they do, depending on some of the obstacles that come up about this handover, what is appropriate, how much we trust this other person. Tell me more about that navigation.
yeah, again, every situation is going to be different. So it really, it has to be conversation. It has to be uh, for the leader. Okay, what would it look like for you? What's the expectation? Is there a precedent within the organization? Sometimes there's not.
Mhm.
But what's the precedent? And if the precedent is you completely close your inbox, you don't even look at it that day, and somebody else handles it, then you and that process is all set up and it's been in play for a long time, then you have to let go of that some. You kind of have to pretend like you're on a cruise and have no internet uh, access. You have to trust and that your colleagues are going to take care of the patients, and it may not be exactly what you would have done with your patients. Again, pretend like you're on a cruise and you have no internet and no way to fix it. But going in and trying to micromanage what's happening is really, really challenging from the start because it just sets up a really difficult dynamic. And so it's all about communicating the expectations. What if there's an urgent message? What if it's a controlled substance? How are those managed differently? All of those conversations. We actually had policies around this because we had so many in our organization. We had so many physicians and clinicians that were part-time clinical and part-time administrative that we had a policy around it.
Mhm.
And so it was just a way for us to be able to manage so that somebody took on that role as like, okay, here's the way we do things. And if there are nuances, then those can be worked out. But it has to be really, really clear in a way that if I if I handed the policy to my teenage daughter, then she could go, okay, yeah, that makes sense. If it's
Mhm.
left to chance or oh, we'll figure it out as we go, that never works.
Mhm. Okay, got it. So there's got to be some thinking about the common things that'll be in your inbox. What's the way we're going to get them out? For your specific schedule for your clinical days, did you have spaces left for your inbox managing person to be able to say, see Dr. Sutton next week, see Dr. Sutton next week about these inbox messages?
Yeah, I did, and I also had really good relationships with the clinicians that were in my clinic, and we would message each other via can't remember the name. There was a secure messaging app, um, and my patients got to know the APPs specifically primarily were the ones that saw my patients and got to know them well, and so and I would also tell the patients because then sometimes the patients feel like, well, you're leaving and I don't know this person, but sometimes that warm handoff can be really helpful. Like, hey, just to let you know, I'm cutting or however the wording is, I'm taking on an expanded leadership role. So sometimes I'm not always going to be here. You're going to be seeing my partner. She's phenomenal. We
Mhm.
text all the time. If she has questions, she's going to follow up with me. I look at your charts. I follow up. And so that the patients don't feel like, well, I'm left out here and I'm never, my doctor's not involved in my care. But that can really go a long way.
Mm-hmm. It's part of well-structured teams and
Yeah.
good team-based care.
Yeah.
Um, is like you say, I'm currently doing some locuming for a colleague who's away, and uh, seeing how this is communicated, but within the clinical space is interesting to see because you're not part. As I'm coming in as a locum, I've not been part of the warm handoff to patients of who's looking after them, where's she gone, what's going on.
Yeah. Yeah. And if it can be done where the patient has the same either medical assistant or LVN, LPN, RN, or some point of contact that's consistent with them, that can really be helpful too. So I've seen that work really well.
Mhm. We've also been in a different location, had a buddy system. So if I was away, my other physician buddy would be the one who would generally be the inbox manager or seeing my patients while they're away. It just created that little bit of extra continuity for the patients.
Yeah. Yeah.
And then making sure that buddy who's left behind as I go away has room in their schedule to take on. And I've got some time
Yes.
in my schedule for when I'm back so they can hand off to my schedule if it's nothing that's urgent and can wait till I get back.
Yeah. Yeah. That sounds like a really,
Just thinking
really
about
good.
how
Yeah.
do we do this in a way that really does help you not feel overwhelmed when you get back from that administrative day and there's a whole lot of things waiting for you that now have to be double booked or attended to
Right.
by phone because that person wasn't left in a way that was capable of handling that for you.
Yeah. Absolutely.
Yeah. Any other great ideas or teams that have implemented things that you've really been proud of?
Yeah, one thing that we started doing at my practice, and I've seen this work well in other practices too, is morning team huddles.
Mhm.
So this is usually after maybe before the clinic opens, but before patients start getting roomed, is the entire healthcare team stands, and the standing is important because if people sit, they tend to linger, but you want to keep it short, 5-10 minutes. Go over the schedule. Are there any pitfalls? Any maybe we would have two patients next to each other and they were both on stretchers. And so kind of, okay, this patient should go in this room, or hey, this patient was just in the hospital. Do we have hospital records? Oh, good call out. We need to call for hospital records. Just looking through the schedule and seeing, are there gaps? Maybe we can call people on the wait list, or is there somebody that hasn't been seen in a while? We're worried about them that we can call and get them in. Are we double booked and we might need to do some shifting? So that is something that I've seen work really well, gets everybody on the same page, and can just make for a smoother day all around.
Mm. Okay, perfect. So that's a good team hint is start to meet together to see if we can get these frustrations out of the way earlier.
Yeah, definitely. Yeah, because you're otherwise you things pop up. I mean, of course, things are going to come up during the middle of the day anyway, but if you can get ahead of them and be proactive about it, I always felt better after that huddle. Like, okay, I feel like I've got a handle on things otherwise I feel like I'm just walking into the unknown.
Okay. What about those clinics where the internet does go down each day, or that second ECG machine is a real bottleneck for the day's proceedings? How do we navigate that with, how do we tell the higher ups that this is a really, really big deal? This is really impacting my ability to do the things you.
Yeah, I think one of the things that my I try to do with my team is to really show the impact on patient care. Because the internet going down sounds like, oh, okay, can't they use paper charts? Well, they can, but if they can't do proper medication reconciliation on their patients, then again, I was in a managed care environments. We were all looking at admissions and ER visits. I might prescribe something that the patient's allergic to. I might prescribe them a second beta blocker, not realizing that they're on it. They might have just come out of the hospital. I mean, you just start, you don't list all the errors, but you really translate it to people that have not practiced medicine but are still making the decisions. Like, this is really the impact of this, and if we don't fix it, it's going to continue to happen. We're lucky that we haven't had an incident or something bad happen, but we want to prevent it from happening in the future. Because sometimes it's just again, it's a work order that's not seen as high priority, or it's from somebody is receiving the notification that doesn't quite understand. Like, yeah, this is a big deal. I mean, if you think about like the airline system, and if there's one glitch and something with air traffic control in Denver, it matters everywhere. And so if we think about it in those kind of in that same vein, then it's a little bit easier to say, okay, yeah, this is a problem and we need to address it.
Okay, so it's just the highlighting the why does this matter in a
Yeah.
language that can be understood by someone who's not necessarily clinical, rather than just getting more and more heated. It's the pause and say, how do I really make this stand out, so that it's clear in its priority?
Yeah. Yeah.
Okay, got it. Anything we haven't talked about that we should talk about?
I think that's it. This has been a great conversation. Thank you so much for having me.
Yeah, no worries. Where do people find you if they're looking to learn more?
Yeah. The best place is my website. It's drlaurasutton.com, and that's Sutton with an I, not an O. And then I'm on Facebook as Dr. Laura Sutton, LinkedIn as Laura Sutton. So yeah, connect with me there.
Thank you so much, Dr. Sutton, for having this conversation with us. Have a great week, everybody. Bye. Hey, if you found this podcast episode helpful, I would encourage you to like and subscribe. Every time you do, you help a colleague or friend find our podcast, and it can help them too. Don't forget to share it along with your friends. If you're looking for extra help, don't forget we have charting champions for physicians and smarter charting for nurse practitioners and other clinicians to help you get home with your work done. We are helping you create sustainable clinical medicine. Thanks for listening.